You are a doctor on duty in the ER at 10 p.m. when two attendants arrive with a patient on a stretcher. The patient is confused and the attendants are extremely anxious, asking you to assess him immediately. You approach the patient and begin your examination. You notice that he is breathing heavily and deeply, a pattern known as Kussmaul breathing. You also detect a fruity acetone-like odor on his breath, similar to nail polish remover. His mucous membranes are dry and his skin turgor is decreased, suggesting significant dehydration. The patient is confused and not fully oriented, although he remains responsive. As with any emergency case, you begin with the ABC approach. First, you assess the airway and confirm that it is patterned. Next, you evaluate breathing by attaching a pulse oximeter to check oxygen saturation. If the oxygen saturation is below 92%, supplemental oxygen should be administered. If it is above 92, oxygen may not be necessary. You then assess circulation by measuring the patient's blood pressure and pulse. After that, you perform a bedside random blood sugar test, which is an essential investigation in any patient presenting with altered mental status. The glucometer displays high. This means that the blood glucose level is more than 600 mg per dl. At this point, two differential diagnoses come to your mind: diabetic ketoacidosis and hyperosmolar hyperglycemic state. The presence of Kussmaul breathing, fruity breath odor, severe hyperglycemia, and dehydration strongly suggest decay. You urgently send investigations including arterial blood gas to assess pH, serum electrolytes to check for potassium levels and calculate the inine gap, serum ketones and urinary ketones, and blood glucose measurement. Meanwhile, you ask the nursing staff to establish a large bore IV line and begin fluid resuscitation with 1 liter of normal saline over 1 hour. You also catheterize the patient, as accurate monitoring of urine output is essential. Soon, the ABG results become available. The pH is less than 7.3, let's suppose 7.29, indicating metabolic acidosis. The bicarbonate level is below 18 milliequivalent per liter. Serum electrolytes reveal a potassium level of 4 milliequivalent per liter. You calculate the anion gap. The normal anion gap is 10 to 12 milliequivalent. Here it comes as 20. That suggests high anion gap metabolic acidosis. Serum and urinary ketones also came positive. These findings confirm the diagnosis of diabetic ketoacidosis. After confirmation, you initiate treatment. You administer 5 to 10 units of regular insulin subcut and the same dose intravenously as a stat dose. Regular insulin infusion is then started according to the patient weight. An insulin infusion is prepared by adding 100 units of regular insulin to 100 ml of normal saline, resulting in a concentration of 1 unit per ml. The infusion is then started at a rate of 0.1 unit per kg per hour. For example, a 70 kg patient multiply 70 with 0.1, that makes 7 units per hour, 7 ml per hour. Mean the infusion will goes to the patient at 7 ml per hour. Now, fluid displacement is continued as follow, as shown. First liter over 1 hour that has already been administered. The second liter of normal saline over 2 hours, third liter over 4 hours, fourth liter over 6 hours, and the fifth liter over 8 hours. And during this time, the patient vitals and blood glucose would be monitored hourly. ABGs and electrolytes are reassessed every 4 hours. Particular attention is paid to the pH, bicarbonate, sodium, potassium, anion gap, and blood glucose level. If the potassium level falls below 3.5 milliequivalent, potassium replacement should be started. Typically, in ward setting, 1 to 2 ampules of potassium chloride are added to 1 liter of normal saline, starting from the second and third. Like the second and third liter of normal saline, 1 ampule of potassium chloride are added to each. But if the potassium level is more than 5.5, you withhold potassium chloride. Potassium supplementation is usually required because the insulins will draw the potassium into the cells, causing hypokalemia, which can cause deadly arrhythmias. The blood glucose should decrease gradually. If it falls too rapidly, the insulin infusion rate should be reduced to minimize the risk of cerebral edema. If it falls too slowly, the infusion rate may need adjustment. Once the blood glucose falls below 250 mg per dl, 5% dextrose is added at approximately 125 ml per hour. However, insulin should not be stopped. Instead, the insulin infusion rate should be reduced and continue until ketones become negative. Urinary ketones may remain positive for an extended period, so treatment decisions should be based primarily on serum ketones, pH, bicarbonate level, and closure of the anion gap. Decay is considered resolved when the blood glucose is controlled below 250 mg per dl, pH is greater than 7.3, bicarbonate more than 18 milliequivalent per liter, the anion gap become normalized, serum ketones become negative, and the patient is alert and able to eat. Once decay is resolved, the patient can be transitioned to subcutaneous insulin and transferred to the ward for ongoing care. 5 to 10 units of regular insulin should be given subcut. It is also important to identify and treat the underlying precipitating cause. Infection is one of the most common triggers of decay, so appropriate investigation should be performed and antibiotics should be started if an infection is suspected, like ceftriaxone or moxifloxacin. Decay is one of the most common endocrine emergencies encountered in the year. A systematic approach involving prompt diagnosis, aggressive fluid resuscitation, insulin therapy, electrolyte monitoring, and treatment of the underlying cause can significantly reduce morbidity and mortality. I hope now you know the management of decay and won't be worried if next time a patient present in ER and you are alone at the ER setting. Thank you for your time. Stay connected, stay tuned with us. You will learn more.